Thank you, Dr. Chu, for the kind introduction, and good afternoon, everyone. Today, I'll be talking about high-precision cataract surgery, what are its options and advantages, and specifically, I'll be discussing about auto-capsulotomy or auto-CCC, the technology overview, its advantages over manual capsulotomy. So as we all know, the various technological advancements that have been continuously happening in the field of cataract surgery have literally transformed the procedure into a refractive procedure. A continuous curvilinear capsulorhexis or the CCC is the most widely considered the most important step for consistent and predictable outcomes, because depending upon your CCC size and position, the lens position also depends. So that's very important for the effective lens position. And the various notable advancements in IOL technology related to advanced optics and materials. So nowadays we are having presbyopia correcting lenses, multifocals, torics. So it's very important to achieve a stable lens position at the end of the surgery, for which capsulotomy is very important. And these have further heightened the importance of capsulotomy during phacoemulsification. So as we all know, the ideal anterior capsulotomy should be circular, of an accurate size of 5 to 5.5 millimeters, so that we can get a good overlap of the optic rim. So this should be centered on the patient's visual axis and should achieve a 360 degrees rim to optic coverage, and must also have adequate capsular edge strength. If the capsulotomy is poorly sized, it can consequently lead to IOL malposition, which could be in the form of IOL tilt or decentration, which can affect the quality of vision due to increased higher order aberrations, and it can also lead to higher rates of PCO formations. So challenges with manual capsulotomy, the biggest challenge is that it is not always reproducible and consistent, and it needs much higher degree of skill and experience. It is also based on surgeon's judgment, and the position and shape of the capsulotomy are the function of various factors such as pupil dilatation, Purkinje images, grade of cataract. Based on all these factors, the surgeon decides where to make the capsulorhexis, how big it should be. All these can actually influence the creation of a capsulotomy. Now, what is the need for automated capsulotomy technology? Why do we need these technologies? So again, as I said, we have premium lenses nowadays, torics, multifocals, extended depth of focal lenses, which offer increased spectacle independence compared to monofocal lenses. But very important thing about these lenses is that they are very sensitive to alignment, position, and centration. So if a multifocal lens or a toric multifocal lens decenters in the post-op period, it will lead to higher order aberrations such as coma and affect the quality of vision. It can increase the post-op dysphotopsias and the contrast sensitivity. So you'll have unhappy patients. So this is why there is definitely, in the modern cataract surgery era, we need automated capsulotomy technologies. So the advantages of these technologies would be, they provide perfect IOL centration with good overlap with the optic rim, maintaining a stable position, thus having a minimal effect on the effective lens position in the long term, reproducible and repeatable results, safe in complex cases. So many times our cases are complex, mature cataracts, intumescent cataracts, cases with pseudo-exfoliation. In these cases, again, it's difficult to get a perfect manual capsulotomy. So automated capsulotomy technologies are of great help in these scenarios, and they also reduce chances of PCO. So FLACS, or femtolaser assisted cataract surgery, as we all know, has challenged the place of manual CCC as the gold standard by theoretically offering more consistency, circularity, and centration. So definitely FLACS has been a revolutionary technology that has changed the face of cataract surgery by giving us, by standardizing this very important step of cataract surgery, which is capsulotomy. And no matter what is the case, whatever you feed in the laser, the machine will certainly give you. So that's why the FLACS technology has become quite popular. However, the adoption of this technology is still nominal because of the issues of affordability and also compromised workflow to some extent. However, FLACS has definitely highlighted the value of an automated capsulotomy, as there are numerous studies which are published that have demonstrated improved accuracy for centration, size, and circularity. So this was a study by Tackman et al., published in JCRS, and the authors showed that the mean deviation in the laser group for capsulotomy from the target was 0.16 millimeters versus manual capsulotomy, wherein the mean deviation was 0.42 millimeters, and this difference was statistically significant. The authors concluded that laser anterior capsulotomy created a more precise capsule opening than CCC, and the buttons created by the laser procedure were easy to remove at the beginning of the cataract surgery. This was another study which was published, and in the 18-month data, the authors showed that femtocapsulotomy showed higher stability and circularity with less PCO compared to manual CCC. Now, this is another study where the authors concluded that femtocapsulotomy showed better circularity, more predictable size, IOL centration, as well as refractive results compared to manual CCC at the end of 24 months. Capsular edge strength is a slightly controversial topic here. There are some studies which show that the manual capsulotomy has a stronger edge, and there are some studies which show that femtocapsulotomy has enough strength. This particular feature is very important because nowadays we have capsulotomy fixation lenses. So these lenses are fixated onto the capsulotomy, so it is very important for the capsulotomy to have adequate strength, and also to prevent the risk of radial anterior tears that can extend posteriorly and lead undesirable complications. So this was a study performed on porcine eyes, and in this study the authors found that the strength of the laser capsulotomy was significantly better. The capsulotomy was precise, accurate, reproducible, and stronger than those created with conventional manual techniques. However, the strength of the laser capsulotomy decreased with increasing pulse energy. So when they increased the pulse energy for the capsulotomy, the strength reduced. So what it concluded that if you use less amount of pulse energy for the capsulotomy, you will have a stronger edge. Now, there are various femtolaser platforms available in the cataract surgery market today. So most of these platforms, they have the capsulotomy depth settings of minimum of 200 microns to a maximum of 1,500 microns. So we have the Lensar laser system in our hospital, and the limit of capsulotomy depth with this machine is 400 to 1,500 microns. So you can, depending upon the case, select what depth you need. In our hospital, for most of our cases, we use 1,000 micron as a standard depth. So you can see with this laser, we get almost every time 100% free floating capsulotomy. So on the left side, we have a very soft cataract, and you can see how easily the capsulotomy comes in the phaco probe. There are no adhesions or attachments. On the right side, I have a case which is mature, intumescent, and very hard cataract. And in this case as well, we are able to achieve a perfectly free floating capsulotomy. So it's very important to optimize the laser, of course, that the company does. So in our system, our machine, the edge height of the capsulotomy is set at 1 millimeters or 1,000 microns. The shot or spot spacing is 4 microns, and the laser energy works best at 5 millijoules. I just had a first-hand experience on this lens, the Femtis lens from Teleon Surgicals. So more is coming on this lens by Dr. Jodhbir Mehta. So this particular lens, you can see in this case that this lens actually has 4 haptics, the 2 routine and the regular haptics. Hydrophilic haptics are the plate haptics, and then it also has 4 extra haptics. 2 haptics are these flap-like haptics, which you need to bring it over the capsulotomy edge at 6 and 12 o'clock position, and the smaller haptics you just need to adjust over the capsulotomy edge. So in this way, the lens fixes onto the rim of the capsulotomy. And you can see at the time of this maneuvering, there was no stress on the capsulotomy and no radial tears of capsulotomy were observed. So this shows that the capsulotomy achieved with laser, femtolaser, is strong enough. So as I said, we get free floating capsulotomies facilitated by lens tilt compensation. This laser also has a special feature of intelli-axis, wherein for toric lenses, it provides 2 notches on the steep axis based on iris registration for toric lenses as well as arcuate incision placement. So coming to the other technologies which are available, the Zepto Precision Pulse Capsulotomy, or the PPC, was FDA approved in 2017, and this consists of a small console connected to a disposable handpiece with a low profile silicon suction shell containing a flexible nitinol ring that delivers thermoelectric energy. So once this shell, it creates 360-degree apposition with the capsule, it releases quick pulse of energy to produce cleavage of the anterior capsule with a resultant round capsulotomy of about 5.2 millimeters in diameter. So the advantages of this technology over FLACS basically are that it does not require additional space in your OR. The time taken for capsulotomy is shorter, less than 5 milliseconds. It can be seamlessly introduced into the normal operating sequence, and of course the cost is comparatively less, and this is why it is also popularly known as poor man's femto. And there are some studies published with this technology, and early experience has shown favorable, consistent results with potential value in complex cases. However, there have been reports of radial tears and incomplete capsulotomies with the use of this device that prompts improvements and further modifications in the technology. And there are also certain user-dependent factors identified that can contribute to the success of completion of the capsulotomy with this technology. And additional studies still are required to further evaluate the performance of this device. Then we come to Capsular, or selective laser capsulotomy. Now, this is a new technology which is currently under investigation. It's right now not available in the market. However, it takes the advantage of the established FLACS technology to create an anterior capsulotomy in a more efficient capacity with a transportable attachment to the surgical microscope. So basically, the laser is delivered through a transportable attachment on the surgical microscope. So in contrast to FLACS, however, the laser energy is continuous rather than the pulsed. So this is how it kind of works. So you first need to apply trypan blue and to stain the anterior capsule. And then the laser projects a reticule as a guide for centration, which is adjustable from 4.5 to 7 millimeters diameters. Followed by this, laser is fired and capsulotomy occurs with laser energy absorption of the dye-stained anterior capsule. The flap can then be removed out of the eye. So this is one publication of this technology which shows that in addition to the advantages related to the efficiency, the authors demonstrated that SLC may provide a more stabilized, strengthened anterior capsule compared to manual CCC and FLACS. So this is another technology which is under investigation, Aperture Continuous Thermal Capsulotomy, or the CTC, from International Biomedical Devices. So this is another option on the horizon that is currently undergoing preclinical testing, is not commercially available yet. So this consists of a small console that delivers thermal energy through a steel ring-shaped cutting element. So once a 360-degree contact with the anterior capsule is created, thermal energy is delivered that melts the collagen on the anterior capsule to create the capsulotomy. So to conclude, quick and precise and reproducible capsulotomies continue to be sought after by surgeons for optimized outcomes without sacrificing time and efficiency. There is certainly a trend towards a guided or automated approach for improved reproducibility and precision, particularly with IOLs with advanced optics and the premium IOLs. However, there is no clear evidence to support whether these automated approaches do lead to superior outcomes or not. However, as new devices are introduced, comparative studies would be helpful to evaluate the performance and determine whether their improved geometry would translate into meaningful benefits for patients or not. However, in my experience of using FLACS since past almost 10 years, I have seen that the confidence that you have, especially while performing your premium IOL cases, that you are definitely going to get a well-centered, perfect capsulotomy and a free-floating capsulotomy all the times. It just makes you feel very confident while performing your surgery and in achieving good results for your patients. Thank you so much.